A nurse practitioner is a registered nurse, first and foremost, but a registered nurse who has undergone further education and training in a particular area of specialty often, that allows, and they're often very experienced nurses, and the idea of being endorsed as a nurse practitioner means that they've been approved and authorised to do some particular aspects of care that other registered nurses are not authorised to do. So a nurse practitioner within their scope of practice can prescribe drugs or order tests or make referrals.
Nurse practitioners have been in Australia for, now over a decade more. And what we bring to clinical care delivery is a level of clinical expertise within a specific specialty, and also we bring research experience and research interests, and also leadership skills as well. So we're well placed to provide nurse-led care within a clinical context, but also within a leadership framework as well.
CNSA's position on nurse-led survivorship care is one that's certainly supported. We know that nurse-led care is equal, at least, to physician-led care, and has some advantages over physician-led care in a broader sense of supportive care. So it's certainly one that's supported by the society. The role of the society is to provide a peak supportive body for nurses who work in cancer care, and through that improve the education of cancer nurses and make sure that the care given to patients by cancer nurses is the best that it can be. Also, it has an objective to increase exposure of cancer patients to the possibility of excellent nursing care. So the impact of having a cancer diagnosis or having cancer treatment is something that nurses are really expert at. And a nurse, certainly a nurse-led or a nurse practitioner, has the experience and capacities to actually look at those features, assess them, make plans for them, diagnose them, intervene, and then review what's been going on from that broader perspective, not just focusing on the cancer itself. The nature of the work, the nature of the condition, the nature of the needs that patients have who have cancer or are being treated for cancer are really suited to the type of care that a nurse can provide. So I think it's absolutely the place where senior nurses, particularly roles like nurse practitioners, can have a major impact. Certainly nurses and senior nurses or senior clinical nurses, advanced practice nurses, have the capacity and experience to identify needs, supportive care needs, and also health behaviour needs, that they can work with a patient to set goals, to change some of those maybe riskier behaviours or ones that don't promote health over time, and work with patients to set those goals to help change those behaviours, to decrease risk of recurrence and those sorts of things. Other social type issues like finances, family care, and the emotional impact of the cancer diagnosis, and identifying where patients might be able to get assistance or plugging in resources that deal with some of those particular issues.
My role is multifaceted. I'm a nurse practitioner in clinical haematology at Peter Mac and the Royal Melbourne. And so my primary role is as a clinician in the care of people after they've had allogeneic bone marrow transplants. The clinic itself is nurse-led, which is quite unique because many late effects services, long-term follow-up services are physician-led. The value in having a nurse-led clinic is we bring our whole-of-patient approach to the late effects, long-term follow-up survivorship care, and also in addition to the expertise and the experience that we bring, there's a real continuity of care that the patient experiences. They see the same group of people year after year, which is part of our model of care, that people come back on a yearly basis for a review. the journey for the patient begins a couple of months before they come to see us the first time. So we get in touch with them, and so that's usually the clinical nurse consultant for long-term follow-up who works in our team, or myself, and we introduce ourselves and talk about our model of care, send out some information about our clinical service delivery model and, the different options available to patients. And then we also send them out some really important patient-reported outcome measure surveys, where they can explain to us about what's going on in their life, both from a quality of life perspective, but also in terms of their physical activity, their health behaviours, so all of those sorts of things. And we encourage patients to send them back in advance of their appointment so we can review that information and discuss it at the multidisciplinary team meeting that we have prior to the patient's clinic review. Our clinical nurse consultant, who goes through their patient-reported outcome measures with them, talks to them about healthy behaviour and screening, appropriate screening. And then they come in and see one of the clinicians for their long-term follow-up clinical review. So the value for patients having healthcare professionals from a number of different disciplines is that you have people who the patient has access to and who are reviewing the patient, who are seeing the patient through different lenses. So they're bringing their own expertise, expert opinion, advice, but also the patient has the opportunity to have a conversation with each of those people as well. So another thing that patients really find beneficial is that we provide them with an annually updated summarised care plan. Our front page has categories of recommendations that we will do for the patient, what we'd like the GP to arrange for the patient, but most importantly, what we would like the patient to do for themselves. So I think that the value to the broader haematology team is firstly all patients who are 2 or more years after allogeneic transplant and who are in remission automatically transition to our clinic. So there is peace of mind for our team that patients are being followed up for any late effects associated with their treatment in an evidence-based fashion. So they know that will be completed. They know that we do not replace their very important specialist care, so they continue to see their haematologists as need be. They continue to receive community care through their GPs, and we communicate closely with GPs as well, and that's very, very important. There are logistical things that you have to consider as well, including room availability, clinician availability, scheduling, advertising, how you will communicate with patients about their appointments, how you will schedule their appointments to ensure that you are not having too much of an impact on their lives. We also, and I think it's really important to think about delivery of consultations. Is it better for patients to come in and have a face-to-face review? Or are they well enough to have a review via telehealth? Are they someone who would benefit more from having their GP provide their care? Can you provide the GP support to provide that care? You also need to be flexible in terms of what you're going to do after the clinic. So if you want your patient to have a number of investigations and they live in the country, is it better for them to have those investigations done closer to home? But what are the implications for the patient? And all of this can be really easily resolved through conversation and communication with the patient and their family.